Okay, so we will get started. So just a brief hello, because I know everybody has read, and also probably you all know about David Schechter anyway, Dr. David Schechter. So David, you're one of the people I think who has worked the longest in this field, having, it's well over 30 years now since you started doing this work, isn't it?
It is. I started when I met John Sarno and worked and was a patient of his, and then subsequently did a follow-up study in his office in the early 80s as a very young medical student. We won't say exactly how young, but very young medical student at that time. And, and so I've been in the field for a long time, and it's been very exciting over the last 15 years as many more practitioners have come on board, and we've internationalized, and we've gotten together a few times, and it's all very good.
Yeah, fantastic. So as we met back in 2009, and then there have been a number of conferences since then over in America, and the couple that we've put on over here at the Royal Society of Medicine. So it's fantastic to have you here to be able to talk about your work with your experience, David. So thank you. And I know, first of all, David would like to know what everybody's background is. So just very briefly, and within a minute, if you could just give a brief explanation as to your professional background and your experience. And shall I don't know if you've all got the pictures in the same place as I have, but have you all got David on the top left and me next to him? No, okay. So what I'll do is shall I just say a name, and then if you could then just give us a brief background. And remember to unmute yourself, please, before you say anything, because some of you are muted. So Lizzie, you're next along from me that I can see. So would you like to tell us who you are, please?
So I'm Liz. I'm a GP in Birmingham.
Right.
I've known Georgie since 2015. Done the training, and I now use it in my practice in various ways, in small nooks and crannies of time.
Yeah.
And also I do see some private patients as well, but mainly NHS patients.
Okay.
Thank you, Lizzie. Drew, you're muted though.
Yeah, my name's Drew Coverdale. I'm a physiotherapist. I've got 22 years. Came across Georgie's book about 18 months ago, I think, roughly something like that, through coming across an alternate technique. And bought maybe 10 of Georgie's books since then, passed them round. I've got loads of Georgie's pictures all over my house, and my wife's been content and enjoying working in current pain after being on the dark side for 20 years.
Brilliant, thanks Drew. Damaris, you're muted as well though.
Hi, I'm Damaris, and I'm a physio in Cambridge, and I work predominantly with musculoskeletal patients, and came across Georgie's work. Ooh, God, Georgie, how long ago?
3 or 4 years ago?
3 or 4 years ago, yes, and did the training, finished the training a couple of years ago, and I'm incorporating it into my practice.
Thank you, Damaris. And Tina, if you'd like to unmute yourself.
Hi, I'm Tina. I'm a psychological practitioner, CBT and mindfulness. I had fibromyalgia myself up until about a year ago, and I'd come across the work of John Sarno, found Georgie's book, Curable app, and then came in via that route, and now doing the training with Serpa, and hope to be completed within the next few months, and yeah, incorporating it in my practice. I was working within the NHS as a therapist, but recently resigned and am now doing the work privately.
Mm-hmm.
Thank you, Tina. And Carolyn, you are muted though, if you could unmute, please. Thank you.
All right. Okay, so I'm Carolyn. I work as an osteopath in private practice. I've been working for about 30 years. And I came across John Sarno's work through a patient, actually. And then that led me to Georgie. And suddenly it seemed like what I've been looking for a long time. And so I've just started the training. I started, stopped, and then started again. So getting going again. So that's me. I'm looking forward to being able to incorporate it into the practice. Yeah.
Great. Thank you, Carolyn. And Emma.
Hi. So I came across this work through your book, actually, that a friend of mine gave me, David, Think Away Your Pain, and started getting better that way, and then came across SERPA through trying to find out who else was doing this in the UK. So I started doing the training about a year ago, and I have been trying to, I'm a social worker, I didn't mention that, did I? So I'm trying to kind of move from local authority social work into doing this more in private practice. That's going slowly. And I'm kind of trying to complete my case studies for SERPA at the moment.
Thank you, Emma. And Liz.
Hi, I'm Liz. I'm a physiotherapist and have trained on Georgie's course about 18 months ago. For about 5 years I've been working. Up to that point I've been working in pain management, and then came across Georgie's course and did that, and have been involved in a pilot running the SERPA programme in the NHS, which I completed that in April. So that's me.
Thank you, Liz. And Catherine?
Hi there, I'm a physiotherapist. I've been working musculoskeletal for, I guess, 20 years or odd, and came across Georgie's work probably about 5 years ago, and then trained with her and finished about a year or 18 months ago. Yeah, and I incorporated as much as I can. Even people coming in for physical problems, I will start to introduce some of the SERPA ideas as soon as I can. Yeah, that's as well as just, you know, seeing SERPA patients as such.
Thank you, Catherine. And Encarna in Spain.
Thank you, Georgia. Hello. Long time without getting into a webinar. My moving to Barcelona has been quite busy, and you know, it takes a lot of effort and to have the head in 2 places at the same time. Anyway, I'm very happy because I'm introduced myself as a physical therapist working in SERPA approach, and my moving to Barcelona is mostly because I want to start hands off completely only in SERPA approach in Barcelona. That's why I'm moving there. It helps me a lot. It's been helping me a lot in this transition to work in this approach. Starting all over from scratch, in a new place, it makes it easier to introduce only this approach, not like in my hometown where I work more than 30 years as an osteopath and physical therapist, where everybody knows me hands-on. That's quite more difficult to start. I mean, to work in this approach. So basically, this will be my introduction. Thank you, Georgie.
Thank you, Encarna. There you are, David. That's
all right, that was very helpful to know who's here today. I know there's a lot of physios. There's a number of people with medical backgrounds in psychology as well. And hola, Carla, hablo español también.
Sí. He sabido de ti, de tu libro recientemente. Hemos estado en contacto. So, let's switch to English.
All right, so we'll switch back to English for everybody, but I do speak a little Spanish. It's very helpful, and I know that some of you are either in the transition process or haven't been doing this work for that long. So I think that perhaps at some point we can get into a little bit of discussion of ideas I might have in terms of practice management or developing the practice or those kind of things, in addition to the content material that I'm going to start off with speaking. But I'm really looking forward to hearing a little bit about the challenges you face and some of the excitement that you have over doing this type of work for those of you who are relatively new to it. I thought before I start, I would acknowledge, since we are speaking from the United States, United Kingdom on June the 5th, a day before the 75th anniversary of D-Day, which for you, some of you who may be history buffs, or some of you who have a more personal connection to the event. My late father was in England in 1943 and 1944, and then made a little trip across the English Channel to Normandy. And so I did want to acknowledge that today. And we'll move on to medicine from history. So I was going to start out today talking about a concept that I do discuss in my book as well, called the 7 Lessons of Pain. And I think just to kind of lay it out here, we'll share the screen for a moment. The 7 Lessons of Pain was a concept that I came up with for trying to explain both to the practitioner and also to the patient. And of course, my book is designed primarily for the patient, Think Away Your Pain, but is also has sections for the practitioner. And some of you are very familiar with many of these concepts, but I want to try to see if we can elaborate upon some of them and show you how you can utilize this information both for your own knowledge, but also to educate your patient. And as John Sarno would say, education is the penicillin for this condition. Mm-hmm. There are other treatments as well, but education is obviously a key element to treating chronic pain and TMS and SERPA and PPD. So lesson 1 is that the cause of chronic pain is often the nervous system and the brain, not structural injury. And this is a concept that both practitioners and patients have a very difficult time dealing with, because when they think of their arm hurting or their leg hurting or their back hurting, their brain and all their thinking process localizes to that area of the body. And they become very conscious of anything that they feel in that area. They become very conscious of anything that a practitioner has said in relation to the structures of that area. And that becomes part of the loop, part of the neural pathway, part of the stuck, broken record for those of you who are old enough to remember records. And I know they're coming back a little bit, so even younger people know what an LP is now. But that stuckness, that sense of not being able to get out of a pattern, is very much related to a misconception of pain, which is that it is due to a local structural problem. Oop, I think I opened the wrong document, excuse me. And often, obviously not always, because if you broke your arm and it hurts in that break, it's probably purely a structural problem at the beginning. But chronic pain is often, if not always, due to the nervous system and the brain. And the nervous system is not just the brain, it's also considered the peripheral nervous system and the spinal cord and all of that. But really what we're talking about is the mind, brain, and emotions. And so that's the shift that has to occur for patients and obviously for the practitioner to be looking at the chronic pain as not a problem of the local area or structural injury, but of the nervous system. The second lesson, which is also difficult for people to sometimes conceptualize, is how important the context and the interpretation of the pain by the patient and its perceived significance. So people have a pain in a particular area and they perceive that that problem is not going to go away. And they're very focused on that problem. They're very focused on their back. They're very focused on it being due to a spondylolisthesis or being due to a small disc bulge. And what they're not aware of is that 2 things are extremely important: the context of the pain and the interpretation of the pain. So the context obviously is what you do as practitioners, is to shift the thought, to shift the discussion from where it hurts to what was going on in your life when it started hurting or just before. Or in the case of pain that started perhaps physically, but then persisted far longer than it should have, which certainly is something that the physios are seeing on a regular basis. What is the context of the period of time in that person's life after the pain started, but as it became entrenched in the nervous system? So that's the period from 2 to 3 months up to 6 months, the process of chronification, or the pain becoming chronic. And that's really when that shift is occurring in the nervous system. and which is evident on some of the functional MRI imaging, the difference between the acute pain and the chronic pain and where it's localized in the brain. So the context of the pain, you know, one of the examples of this that was given by Dr. Sarno years ago, many of you may be familiar with it, I've discussed it as well, would be the difference in context when a soldier is shot in the foot, has initial pain, obviously is administered to in some sort of first aid, but then realizes that he's going to be getting away from the front lines, he's going to live, he's going to be able to go back to some first aid station or perhaps be removed completely from the battlefield. Obviously, we now understand there's things like endorphins that are released. That patient may require no pain medication at all, versus the context of being in one of the cities in the United States that has too much violence, or a city in Europe and someone being shot in the foot, perhaps in a gang event or some other type of violence, unexpected violence. And that same exact injury in that different context can be vastly more painful for that individual, because he does not know if someone's going to come back and shoot him and kill him. He's wasn't expecting that he would be in a combat type situation. It's not combat, it's an urban environment. And so that same individual in two different contexts experiences pain completely differently. This has been reported from just after World War II, and Sarno took it up, and then others of us have found this to be a very important analogy for patients and for practitioners to understand. And the second part of lesson 2 is the interpretation of the pain by the patient and what they perceive to be the significance. So when you change for the patient, the interpretation from, oh, this is just benign, soft tissue, muscle tension. If you like the ischemia model, you can say it's related to decreased blood flow to the area. If you don't like that model, which again, there's some controversy scientifically over that particular interpretation. Again, just the idea that this is benign pain, it's more related to your mind and emotions than it is to anything going on in your body. Changing that understanding, changing that interpretation. I do that quite a bit when I look at MRIs with patients, and some of you who are physicians or perhaps physios can do the same. I actually look at the images with them because I have a fair amount of training in doing this. And when I can explain to them that this finding that they've been told is, quote, degenerative disc disease or a herniated disc, I put those in the little air quotes, in fact is normal aging of the spine. And I say to them, just like you have gray hair on your head and it doesn't hurt you, this is just gray hair of the spine. And this also does not need to hurt you. And so that changes the interpretation, it changes the context, and it's a very important part of what I do and what you do. Lesson 3, psychology and education can change the mind-brain and cure pain, not just manage it. So this is an interesting one, because you are trained in pain psychology, either because you are yourself a psychotherapist or because you had training of that in your medical or physio background. Traditional pain psychology teaches the practitioner that you can help the patient to perhaps shave 10 or 15% off the top of the pain. And that's about as far as you're going to get. And that is such a defeatist attitude, because as we know, those of us who have done the work or had the personal experience or both, you can get the pain to go completely away in some or many patients, and you can get it to go mostly away in other patients. And so there is no self-imposed limit of 10 or 15%. There should not be a self-imposed limit, because we are actually changing the brain, and we're changing the nervous system, and we're rewiring pathways by this psychology and education, or as it's now often known, psychoeducation. We're not just managing pain. So this is a transformation that has to occur in the practitioner's approach, and then has to be transmitted to the patient for them to understand that they can actually get better. With the goal of 100%, I don't say that everybody gets to 100%, but as long as that's the goal, you get a lot farther. And I'll come back to that in question and answer for sure, because that may bring up some questions. Lesson 4, which I believe is still on your screen.
Not at the moment, it's not.
It's not on the screen. Okay, I'll share it back. Let me see if I can. There we go. Thank you. Sharing it back. Oh, that's not sharing it back.
Oh, yeah. Oh, no, it's not.
There? No. Do you see it?
No.
Okay. Trying again. Little technology failure here.
I think we're seeing somebody help me here. Google or Zoom in the background.
All right, I'm stopping to share. I'm going back to share. Okay, now you're seeing it, correct?
Yes.
Yeah.
Okay, so lesson 4 is that pain does not always mean disease or damage. This is another one of the key principles that has to be, the person has to be educated about, understand, and internalize. And those perhaps are the stages in that case. When you put your hand in a hot boiling water and you pull it back, obviously the pain is telling you, get out of there, you're going to get some damage. And if you have a bad infection in your leg and it's swollen and it's painful, it's also telling you you have a disease that needs to be treated. So we begin to, from a young age, we begin to internalize the message that pain means something in the category of disease or damage. But of course, there are benign types of pain. There are pain in the muscles that is quite discomforting, but which has no great long-term significance. And when one understands that, one can begin to eliminate that pain. But I find that this is something that people struggle with. And what we do is we teach them that the pain is a form of a signal or a signaling device, but it's a message that you have to learn what to hear, that you have to stop thinking of it as it's telling you about damage and start listening to it's telling you that you're not handling a particular relationship well, or that you need to reevaluate your work situation, or to try to develop a new type of relationship with your supervisor, or you've got to express those feelings that are building up about your teenage children and other challenges in your life. So that is the redefinition of pain from disease or damage to something else usually emotional that's been internalized.
We're not seeing the PDF again, I'm afraid, David.
And we'll get it back up there. Not sure about, all right, so we're sharing and we're going back to 7 lessons of pain. Are we there?
That's it, thank you.
All right. Lesson 5. The severity of the pain does not always correlate with the severity of the condition or the potential damage to the body. First of all, let's look at this in more traditional medical or healthcare explanations. A kidney stone can be excruciatingly painful and is obviously expressing a physical process, but typically a kidney stone passes and within a half an hour, the person is ready to go out and play tennis. They're not really in pain at that point at all. And so there was no great damage that occurred. The potential damage was relatively low, but it was a very painful process. On the other hand, a heart attack can present subtly with discomfort in one's neck or in one's left arm. Obviously, it can also present less subtly with a squeezing sensation in the middle of the chest. And we see here that a very dangerous process like a heart attack could present very subtly, or cancer in its early stages might present with a subtle discomfort in the abdomen or somewhere else and represents potential damage. But something benign like a kidney stone or something wonderful like childbirth can be very painful, but not lead to any long-term, hopefully, damage to the body. And so this is another lesson that we have to, in a sense, re-educate people from what their intuitive experience has been, which is that pain and that risk for damage are the same. Another example in the musculoskeletal field is that back attack that someone has. Someone bends over and has this just excruciating pain in the back, feels like a knife is going through their back. And of course, a lot of worry with that. And sometimes they can't move very well initially. But typically that attack goes away in a matter of a few days, almost regardless of what is done. And everyone in musculoskeletal, and many of you personally may have had that experience, whether that attack was TMS, PPD, or whether it was simply somebody who hadn't been stretching very much and the muscle decided to wake up and give them a spasm, it was ultimately a benign process and did not lead to damage. I'm moving on to lesson 6. So we've been taught to believe and taught to understand, even in our schooling, that pain signals are what's called afferent, and that would mean they're coming from the body to the brain, and that efferent signals are motor signals that are coming from the brain to the body to tell it how to move. But as a result of scientific understanding, some of which was pioneered by a doctor at UCSF, Howard Fields, and some of it in other scientific exploration, we've really learned that pain signals are a two-way street. And so what this has helped me to explain to patients, I'm cutting off the screen now, what this has helped me to explain to patients is that pain is not simply a passive process from body to mind. It's a two-way process. It's a process of the brain and the mind interpreting signals from the body, and then in some cases amplifying, and in other cases diminishing those signals. So if a person is getting a signal from their foot, I hurt, but they have to finish the last mile of the hike, they may be able to ignore that signal and keep walking and get through that last mile of the hike reasonably well. And then perhaps they get back to their home and they can put ice on it or change shoes or something of that sort. That would be an example of the brain making a conscious determination to really dampen down pain. If, on the other hand, a person's getting a pain from their low back in the context of marital discord, in the context of a difficult employment situation, or other stressors, the mind and brain can be sending signals to actually amplify what's being experienced. This is going on without the patient's awareness. And the pain is experienced as more severe than it otherwise would need to be. We can take advantage of this in two ways as practitioners. One is to explain this concept so that people understand that the experience of pain is not just a one-way process. And the second is to empower the patient that what they think, what they feel, what they are thinking about can affect their pain in the body. Because in fact, it is a two-way signaling process. And again, I'll be glad to answer some more questions on that in a few minutes if that's not totally clear. I'm coming back again to sharing and just making sure that it's there. So I come now to my last of my 7 lessons. And this is an important one for practitioners. It's important both for the physical and the psychological practitioners. Mind-body pain keeps coming back until you are firm in your belief, and I'm speaking now to the patient, of course, that there are no physical causes. So people often get hung up, often get distracted, often get worried, and often don't heal because they still have a belief that something physical is causing their problem. And it's incumbent upon the practitioner to do the due diligence, or if it's not your particular specialty, to have someone else assist with the due diligence to ensure that there's nothing structurally wrong, and to ensure that the patient understands and accepts that. So we face a couple of challenges with that, which is in healthcare and medicine, there's almost no limit to the amount of testing that can be done. So we have to find a reasonable ground of testing, and that usually involves some imaging of the area, might involve in certain cases some blood work as well. And I've seen people with, for example, chest pain that I knew was not due to a structural problem with a normal EKG, no family history, relatively young age, but it took a more aggressive heart test for them to really internalize that message. And in some cases, the pain literally goes away within 3 hours or 6 hours of them being told, your heart test is fine, you're normal. Of course, the same thing sometimes happens to people when they finally get an MRI of an area and they're told there's nothing there, whether it's by their regular general practitioner or whether it's by a SERPA TMS PPD practitioner who's reviewed that data. So in the cases where people are struggling with it being physical, structural, it really is helpful to come back and make sure that they're firm in it. I call that accepting the diagnosis at both intellectual and emotional levels. But it's certainly a goal of whatever your style of practice or your expertise is, to make sure that the person's firm in that belief. The belief is not that it's again, we believe this is physical pain, but that there are no causes that are being missed that need to be focused upon in the structural or biochemical realm. And that's the seventh lesson, but it's certainly one of the most important. And we can come back to, well, do I ever believe that there is a mixed picture of pain? And that's something that's for the advanced course, but I think you're generally advanced people, and we can certainly talk about that. So I've spoken for about a half an hour. I think this would be a great chance to see if there are any questions and perhaps to guide my discussion going forward. And I'm happy to speak more on this subject or related subjects if there are no questions.
So don't forget, you're all mute. Most of you have muted yourselves. So if you want to speak, unmute yourselves. Any questions?
Well, a mixed presentation would be good to discuss that you just finishing off with there.
I'm sorry?
Mixed presentation that you were just mentioning then, that would be quite interesting to get further thoughts on that.
That's one of the more advanced concepts, but I'm very happy to discuss it. Now you could say it's a controversial concept. I don't mind controversy. Okay, so those of you who have read Dr. Sarno's work, he's very much a black and white thinker when it comes to what he calls attention myositis or related attention myonural syndrome, right? You're familiar with the term TMS, versus structural. So he would pretty much put, with regard to pain or chronic pain, he pretty much put 95% of things into the TMS basket, and then he would put 5% into, I think, tumor, trauma, and tumor infection, and that sort of thing. I don't.
Cancer
tumor
infection, fracture.
Yeah, tumor fracture and infection. And he didn't really leave much ground for anything else. And so, to some degree, again, I'm not speaking derogatorily of him, but I respect him a great deal. Obviously, he taught me this field. But to some degree, he was able to do that because his patients, the last probably 15 years of his career, were screened quite heavily. Your patients in general are not screened. My patients are not screened. By screened, I mean that if somebody called his office and there was seemingly a more complicated picture, his secretary or he would say, I want you to see this neurologist up at Cornell University in New York City. And if he says you can go forward with TMS, then I'm happy to see you. So that obviously honed him down on the patients that were more likely to have this condition. He said to me he didn't mind that at all. He thought that was actually useful. He said, because if you were the world's best hernia surgeon, you wouldn't want gallbladder cases to be coming to you. You'd want to be seeing hernia cases. And he felt like he wanted to focus on psychophysiologic disorders because that's what he was best at. Some of the some of the rigidity in that area was also related to the fact that, again, he had 35 or 40 years of being surrounded by an entirely hostile medical and healthcare community in New York City, with the exception of a small number of psychologists he worked with and one or two physicians in the area. So he had, and myself, and gradually some more of his mentees or his students, but he had a pretty hostile environment. I think that tends to also create a little more rigidity. So then as I moved on into my career, seeing a variety of people with chronic pain and acute pain, I said to myself, I want to be objective with every patient. If I see somebody who has a large herniated disc pushing on a nerve with their foot, dragging their foot into the office, I personally was not able to say to them in all honesty, well, all you've got is TMS or PPD. I said to them, I see evidence here of a structural process. I certainly at the same time explored their psychological status, and where appropriate, we discussed that and intervened. And then I presented them the data on structural approaches to that particular case, including some data that says that after 2 years, it doesn't necessarily matter whether you have surgery or whether you don't, even for these massive herniated discs. And again, this is not at all related to the 3 or 4 millimeter bulging disc or degenerative changes. There are other things that I believe is completely unrelated to the long-term success of their condition, which I believe is TMS PPD in these cases. But I broadened the category for myself of what I felt could contribute to physical pain, because I felt that it was important for the patient to see me as an objective individual, and for the medical community to feel like I was an objective person who maybe would bridge the gap between a purely psychological approach and a purely structural approach. So they're individuals that I will give a diagnosis of mixed picture. I don't know, for those of you who've read my book, there's some discussion of it in there, but I don't know how much discussion goes on otherwise. Maybe Georgie can tell us later if that's part of her teaching or training or not. But in any event, the mixed picture individual is someone for whom I try to gauge a percentage, and it's very difficult to gauge that percentage. But I might say to them, for example, I think your problem is 30% structural, but 70% TMS. Now, that doesn't mean that I think you can only get 70% better. It actually may mean that you get 100% better, but I just want to acknowledge the fact that there is this structural reality. I also see people who've had surgery, and the surgery damages them in one way or another. And I explain to them that there is some structural damage there, but that, you know, you have TMS, and we can help a great deal of it to go away, perhaps all of it. In all cases, when I mention mixed and I get into it with them, I say to them, I'm really trying to give you an estimate, and I'm not a prophet or a soothsayer, and I can't tell you the exact percentage of either your ability to improve, which I hope will be 100, or of the component of your structural. There's other people for whom I say your problem might be 70% structural and 30% TMS, and we have to discuss where you go forward with that. Do we want to consider medications, anti-inflammatories, Medrol dose pack, which is cortisone pills, and so on. When I spoke with Dr. Sarno years ago, he occasionally would have patients actually get an epidural. It wasn't something that he was keen on, but he said to me, there's people in so much pain that he found that an epidural would give them some temporary pain relief, that they could then sit down calmly and begin to do the TMS work, which might involve psychotherapy, group therapy, educational seminars, books, etc. So this is what I would call the mixed picture. Now, does this diagnosis make it more difficult to treat these individuals? I would say yes. Those individuals for whom I can say, and this is the vast majority of the ones, but those individuals for whom I can say you purely have TMS, it's easier for them to focus, including on lesson 7. It's easier for them to focus on, that's all I have to work on. I don't have to think about anything else. When I do bring up the concept of a mixed picture, I've had very successful outcomes using that concept, but it is sometimes a challenge for people. Well, but you said to me that structural was playing a role. How do I know when it is and when it isn't, and how active I should be, and that sort of thing? So that's my concept of the mixed picture, and I'm happy to hear from Georgie or any of you about either disagreements or thoughts on that, or whether that's something that you consider in your practices or have heard of before.
I think you're right there, David, and I think there are times when it can be very difficult to say, yes, it's 100% TMS. And I agree that, yes, it does make it more difficult, because it's easier for them to just blank it off and just say, right, okay, so I can work on this. And quite often it just helps to help them point out when there's an exacerbation or not, and just start to look at what's going on in their lives and just fit all this in with that. And then the further they get, then often the easier it gets, isn't it? But that's helping them personally look at what's going on. So yes, I agree.
Okay, so I'm glad to hear that you're also open to that concept. And if someone else wants to speak in a minute, I'll just speak briefly, and then we'll let you do that. But really, what we're offering is, in a sense, a different set of questions and a different way of looking at the problem. I have many people who come to see me in my office in Los Angeles who've seen 10 or 15 practitioners before me. I've had people see over 50 before me, over 50. And especially when they go to some of the local practitioners in the Los Angeles area, I often know these people, and they're often the A-list of doctors, orthopedists, pain surgeons, pain doctors, etc. They're not seeing the B and the C list if they get up to 10 or 15. They're often going to the A list, right? And so I say to them, you're not coming here because I'm any smarter than anyone else. You're coming here because, and you'll see, and they often are seeing it when I'm saying this. I don't necessarily bring this up at the beginning, but I may bring it up at some point. What you've learned, what you've seen so far here in your first, let's say, 20 minutes of the visit, is that I'm taking a different approach. I'm asking different questions. Therefore, I can get different answers. And that's why I have success even when other doctors have been unsuccessful. Most physicians in Los Angeles hate to see somebody who has seen 10 or 15 other practitioners because they realize they have nothing additional to offer. I'm actually excited about seeing those people because I have some of my best results. They've already had the nerve tests. They've already had the MRIs. They've already had the physiotherapy. They've already had the chiropractic. They've done everything structurally they can do, and they come to see me. That's going to generally be a winner for me because that tells me that they're A, open to a different approach. B, they've been completely worked up, so we're not missing anything terrible. We would have ended up somewhere along the line stopping on the structural pathway or gotten better. And C, that probably nobody's ever asked them, what's going on in your life?
Yep.
What was your childhood like? And the personality questions I ask, are you a perfectionist, people pleaser, hard on yourself? Nobody's asked these questions, and therefore it's going to be successful for them, and it's going to be a good patient for me to work with. So that's something that hopefully some of you will experience or have experienced, that it's not necessarily a difficult case because they've seen 10 or 15 other practitioners. It's a difficult case when they're not open to listening to this approach, or where a family member brings them in and says, I read this book and found it interesting. Now you convince them that it's this condition. That's a difficult patient. The patient who comes in with a degree of openness and has not been successful with other approaches is often your best patient. You find that as well? I'm open to anybody who wants to comment on that among you individuals. Just unmute before you speak.
I think we've all found that, haven't we? Come on, all of you.
All right, it's a quiet group now. You were very good with
the not always like this.
Getting late over there in the UK, but you were very good in introductions, but you're quiet now. So
yes.
Well, I was going to say the people that I get coming through the SERPA approach, you know, who are coming via the SERPA website, Georgie's SERPA website. They're already there. They're already half believing. But the people that I get coming through the door who are coming to see me as a physical therapist, it is much, much harder. You can see them beginning, the light bulbs going on, and they can say, oh yeah, okay, yeah. But it is hard to keep persuading them. But some get there and some just won't accept it. And they'll say, oh yes, I can understand that for everybody else, but not for me.
Yes.
So I'd like to comment on that because that does represent an important distinction, because I myself have those two groups of people as well. So I have people who come to me having read one of my books, having read one or more of Dr. Sarno's books, other people's books, having seen my work on my website or on other websites, and they're primed, as you say. They're ready, they're open. You know, in my other handout that I talk about with patients, it's in my book, and I might show it up briefly. I'll share it. You know, one of the key I will share it. Why not share it if I'm going to say I'm going to share it? So I call this the 12 stages of healing, and on stage 2, it's becoming open to a new paradigm. That often comes after realizing that existing approaches to pain are not working or are temporary. I'll leave that up while I speak for a second, but this is a process that I call the stages of healing that I go through with patients. So the person who's open and the person who has failed other approaches, perhaps, we'll go back to looking at you guys, but the person who has read a book and gotten some partial relief from that, I agree, those people are, if not easy to treat, more typically successful, and they're a step further along in the healing process. So how do you approach the other group? Because I have the other group as well. I have the group of individuals who doesn't know anything about this at all and comes to see me for general medical care or sports medicine care or pain management care. And as I begin to talk to them, I'm suspecting that this may be a TMS PPD case. So how do you do that? Well, first of all, you accept the fact that not 100% of the people are going to be interested in what you have to say. And that's sometimes difficult for people because there are many practitioners who don't want to have someone say, well, I think I've got to find a new practitioner, or that's not what I want to do. So you have a number of options coming from the most subtle to the most direct. So the most subtle might be to say, I have found that this website or this handout that you have in the office or this book, if you want to go that far, is very helpful for some of the patients that I see who have the condition you have. If you're willing to look at that, we can discuss it again at the next visit. So that's fairly subtle, kind of planting a seed. Perhaps a little more direct approach would be to start asking some of your SERPA TMS type questions and see how they respond to being asked those questions. And if they say, what does this have to do with my back pain or arm pain? Then, of course, you can explain that your pain is more than just a sum of our bones and joints, and that the nervous system is the key element here that is often missing. But you're gonna definitely have people that are open to it and not open to it when you mention psychological factors, or you mention the mind and brain, or you ask them to read something. All I can say on that as well is that there are many patients who come into me having told me that a friend or a spouse or relative gave them one of these books 6 months before or a year before, and they looked at it and didn't seem at all relevant to them. So they put it on the shelf. And anyone who's done this for a while, this story will resonate with you. And then suddenly they pick it up again in the midst of another bout of pain, and they're enraptured with every page it seems relevant. They see themselves in every page, every chapter, and they're picking up the phone and calling and trying to get an appointment with me as soon as they can. The same person who 6 months or a year before had no interest when someone exposed them to this concept. So obviously, as psychologists, those in the audience who are psychologists, social workers, you may be more familiar with the concept of stages of readiness for change, stages of change. This has been documented in the literature over the years, that some people just have to be ready before they can be treated with this approach. And they're ready when they're ready. So we can't always fix them. But by having materials in your office, and if some of you I think most of you have switched from conventional, those of you who are physiotherapists, most of you have switched from conventional physiotherapy to this approach to some degree or another. But there's some conventional physiotherapists in Los Angeles who are at least open to the idea that some of their people will benefit from this approach that I have. And I have relationships with them from those sprained knees and those rotator cuff issues that come up with sports that I've referred to them for treatment. So they'll keep a copy of my book on a table in the waiting room, kind of just a courtesy. And ever so often they'll say, well, somebody was reading your book in the waiting room and they asked me how, how I can get a hold of you or whatever. So there's different subtle ways, and you can do the same thing in your waiting rooms if you are not just doing the SERPA method. You can leave books, flyers, handouts, paperwork. You could have a YouTube video running on an iPad. You can do a number of things subtly that people would be exposed to as they're waiting to see one of the practitioners or you in the physical setting, and it might interest them more. This could be effective in the National Health Service Corps if they permitted you to do it for the physician in that setting. And that sometimes you just have to plant the seed. I guess that's the end of that point. But any further comments on that, or I'm open to any other questions as well.
I like the idea of video going on the iPad. I hadn't thought of that one.
Yeah, but look, some offices in the U.S., I'm not the big fan of this. We don't have it in mind because I find the TV to be distracting. I like people to just come in and relax a little bit. But some offices in the U.S. have television screens either running a news show, or in some cases it's linked into a company that provides a health combination of health videos plus some ads or things on it.
Yes.
But you control, if you get a simple LCD screen of whatever size you choose, and assuming you have the discretion to do this in the setting that you're in, you could run whatever you want on it. You could run slides, you could run a particular YouTube video over and over again, you could run yourself speaking about the subject or whatever you wanted to. But again, it depends on the context of where it would be appropriate and where it wouldn't be. Or you could have something, in the case of the busy NHS physician seeing people every 8 minutes or 10 minutes, if there was an extra room and you had, let's say, 4 people that day that you felt had psychophysiologic disorders, but you just didn't have the time to get into it that day, you could say to them, I'd like you to go to that room in the corner next to the closet and just press play on that computer or in that iPad or whatever, and just spend about 10 minutes watching that. And then the next time they come in, they may be primed and ready to, by then they'll have already read a couple of books perhaps, or looked at some websites as a result of that 10-minute video introduction. If you don't think there's space in your office, then you just print out on a piece of paper 3 or 4 links that you like. I have many more than that I give the patient who's going to be going through treatment with me, but you can give them 3 or 4 links to podcasts, webinars, YouTube videos, and the like that you think they should listen to. And you can say, here's your homework, and I look forward to discussing with you next time. So that takes all of 5 seconds to do that. And even if only 50% of them listen to it and 50% of those get interested, you've still enhanced the healthcare of a quarter of the people you handed that flyer to.
Absolutely.
Okay, I'm saying flyer, that may be an American idiom, so I don't know if that means anything.
No, it does. But I think the main point that you're making, David, is that we can't convince our patients. It's about sowing seeds, and when people are ready, then they will move forward, and not to feel offended when they don't take it on board, because there are many people who won't.
The exciting part of this work is empowering the patient to get better, and the fact that we act as a teacher and a mentor more than a practitioner that does something to them.
Yes.
The challenging part of this work is that it requires the patient to participate, because it's a joint effort. And if they're not ready to participate, we have to be polite and move on to the next person who is ready to participate, and hope that they'll get to the point where they'll be ready as well.
Absolutely. Does anybody else have any questions? This is a very quiet group. Great. Encarna, shall I unmute? I've unmuted you.
Okay. For me, the most difficult is when the people comes and have one practitioner, physical therapist doing regular physical hands-on physiotherapy, and they are coming to me for SIRPA treatment also, and they mix. And the physical therapist is doing one thing, convincing them about the structural work, and they are half and a half. You know what? They have one foot here and the other foot here, and they go, and I have the feeling I'm, for me it's hard to say them not to go to the regular physical therapist. But now I found a shortcut, and it's to tell them at least during 3 months, please don't go. After, you do whatever you want, because in the beginning, I mess up trying to be kind and not to get into, because they are making their life, you know, and I'm just saying, don't go to them. They are my colleagues. And I feel sorry, and then it's all messed up. I don't know if you guys had some of this experience, but for me,
I'll comment on that. You know, obviously, it's easier if you have a physician who's supportive in your community. And I don't know if there is one in Barcelona right now, but
there is one. I think there is one, only one. I still didn't have my appointment with him, but he's keen on, you know.
Oh, well, you should definitely have lunch or dinner with him. But
I'm going to. I will tell you how that is working in the future.
Because
he's a rheumatologist.
I find that one of my key roles is to discuss with people who are doing multiple treatments and find out why they're doing those treatments, how long they've done those treatments, and kind of like you said, I sort of think, let's take a break from the physical for a while and just work in this program. Give me 2 months. And you can always go back, and it's not impolite to tell your chiropractor or your physical therapist that at this point you feel like you've done enough physical treatments at that particular point, and that you'd like to work more in a different model. You don't have to tell them a lot, just as long as you're polite with your appointment cancellation. Most people are fine with that. I know it's difficult to say it, but I often appeal to their time and money.
Yes.
So I say to them, if you take a break from, and again, different healthcare systems, but if you take a break from what you're doing physically, your acupuncture or your physical therapy or your chiropractic right now, and you focus more on your educational and your psychological, you'll kind of be spending less time on one and more time on the other. And let's see how that goes. If the physio that they're seeing would be an ally, then that could potentially be of some help. But that's getting all the pieces together took me a long time in Los Angeles, and certainly will take you a while in Barcelona to find the people that you can work with in a unified fashion, where everybody, when everyone's giving the same message, it really makes it a more successful program.
Yeah.
And the psychologist talked about breaking through the defense barriers that way. You know, if everyone is sort of responding to the patient's defenses the same way, then and speaking the same language, it's very helpful. And by language, we're not talking about Espanol and English. We're talking about psychophysiologic versus structural. There was another question, I believe. Is that right? No?
No?
All right. Does anyone have anything to share from today that they feel like they learned that they can incorporate in their practices? If you would like to just make a brief statement on that, that can be helpful to me for future educational webinars with other groups. If you want to jump in and just say, I learned this, or I intend to use this, do so.
Well, I thought that I've got to do a talk to the local WI, you know, the Women's Institute. And I was thinking, well, where do I get my basic structure from? And I just thought, well, maybe the 7 lessons is a good way of starting and explaining. That would be very helpful. Thank you.
I think you can definitely utilize that, for sure.
Anybody else?
And I'll put it. Oh, someone's had.
No, they're all very quiet tonight. We're petrified, Tina.
If anyone has any questions about, some of you were just starting a practice or just making a transition, if you had any comments or questions on marketing to physicians, meeting with psychologists in your area, social workers, just sort of like that interdisciplinary connection, and how to go about that. Does anyone have any thoughts or comments or questions on that? If not, I don't want to keep you longer than you want.
Liz, go on then.
I will ask one. 4 of us in the geographical area that we're working are hoping to work together through some marketing and to do some marketing together, presentations, etc. But also both to the public, but also to GPs, so general practitioners, etc. And just whether you've got kind of any tips in making those initial contacts. And we want, of course, we want to talk to people who are interested, but just kind of, you know, how to kind of go about that, really.
One thought that came to mind was any practitioner you speak to, and I think a GP would be certainly one of those, is looking for a solution to their difficult patients or the people that they struggle with dealing with. So if you present it in that way, which is, I have an approach that can help you with some of the people you're struggling to work with. And I work with people with tension headaches and back pain and migraines and fatigue and fibromyalgia and these sorts of things. And all you have to do is suggest that they call me up, and I'll chat with them for 20 minutes at no cost. And then I'll schedule an appointment with them if appropriate in my private practice. And it will take some of the burden off of you. I know you have very little time and energy to deal with some of these folks. I'm happy to help you with these people, and here's how I do it. And I think that's what people are looking for, is practitioners are looking for, is help with those that they are not succeeding with. If they were already succeeding, they wouldn't need you.
No, no.
Right? So I think that's how I would approach it.
Thank you very much.
Certainly, when I started this 12 years ago now, I visited all the local GP practices and I asked if I could talk to the whole practice, and I ended up speaking to the GPs, the nurses and everybody. And there was a mixed response, but usually an interest. But now it would be so much easier because there's far more evidence base. Because the one thing that did hold back everybody, and they always picked up on this, was where's the evidence for the hypoxia? And so whereas now the pain science is, there's so much about the pain science that's actually helping support our work. And I know a few of us on this call were at Lorimer Mosley's training a couple of weeks ago. And so the pain science evidence is there. And so therefore it's much easier to demonstrate this when we go and talk to GP practices or physio practices. So it's about, I would suggest, go out and talk to groups of people like practitioners and GP practices, raise awareness initially. And like you say, David, you know, say if there's that you can help with some of their heart sink patients that they call. They'll probably test you with the most challenging ones. Sure. They do that with me. But worth it.
And don't be intimidated initially if you don't feel that you know all of the mechanisms and all of the scientific evidence initially, because I mean, it is possible to give a briefer presentation that because you are a psychologist and they are not. I believe you're a psychologist. I'm not sure if you said physio.
Physiotherapist.
Physiotherapist.
Yeah.
So it's a little bit different, but the point is that when you're talking to people from a different discipline, they just have to feel like you have something to offer these individuals. Occasionally they'll get into more of this sort of debate, science debate type of thing. It just depends how much you bring it up, and then that might be intimidating to you initially. Georgie can certainly help you with that. But I think that for most cases, it's more of that if they feel like you're well-trained and you're motivated, you have an energy level, and you're looking to help people, then they might try referring a few people. And I think Georgie's idea of speaking not just to the GPs, but to the nurses and all of these other people, and you know, it's a healthcare team trying to find solutions for individuals who are struggling to get better. So any one of them might mention your work or your name or pass out your business card to their practice, to their patients.
Mm-hmm. Thank you, both of you.
Well, I enjoyed speaking with you today. I think we're probably wrapping up here.
Mm-hmm.
Have a great evening and a good June 6th.
Thank you very much, David. Really appreciate it. I know everybody will be interested, will have found this interesting, and also we've recorded it so people, all the others, can actually watch it as and when they want. And I was just about to say, we will put a link to your book, Think Away Your Pain, on this, with this recorded webinar. And now, well, they've seen it anyway, and I've got that. In fact, I bought it years ago.
This is coming out very soon. I don't even have it printed yet. I've written one for teens. I want to do a curriculum for middle school and high school students in the US. So these would be ages 12 to 18. and
Brilliant.
expose them to the concepts of psychology, mental health, and how it affects physical health. And so I've written a workbook for teens as part of that curriculum, and I'm also going to put it up on Amazon and things like that. But I'm excited about working with the younger population as a preventive.
Yes.
Brilliant.
Do let us know when that's up, David, because that is something that we're often talking about. Is brilliant. Then we'll put that up as well and tell people and let everybody know on the SERPA page, because that's something that we're all very passionate about, is not just treating people but prevention. And one of the things we've often talked about with various practitioners is being able to address teens but also parents to help young children learn to become more emotionally aware and acknowledge and express emotions. And that's certainly something that over the last year I've been thinking about more and more, and unfortunately this year has not been the right year to start something like that, but definitely it would be really needed.
I'll send you an email on that. In the US, they're starting to call it social emotional learning, to try to bring that into the schools.
Right.
We've got PHSE in the UK, haven't we?
Yeah, PHSE, yes. Yeah. Fantastic.
All
Lovely.
right.
Thank you very much for your time then, David.
David,
meeting you all.
I heard your book is translated to Spanish, isn't it?
Esto en español. Ejercicios mente cuerpo.
Vale. And how would be the translation?
No está en español.
No, but how would you translate that to Spanish, the title? Because it's quite difficult to translate that, isn't it?
Probably.
Think away your pain.
Yes, ma'am. What, do you have any suggestions? You can email me.
Yeah, I'll email you because it's quite tricky, that name. Okay, I'll email you.
Hasta luego. Goodbye, everybody.
Goodbye, everybody. Thanks very much.
Thank you.